Well, very good evening to all of you, and good morning and good afternoon to all others who are joining from rest part of the world. Today we have got two guest speakers. The first one is Dr. Akanksha Garg from Ahmedabad, and the second one is Dr. Prantar Chakrabarti from Kolkata. The first guest speaker, Dr. Akanksha Garg from Ahmedabad, is going to lecture us on managing polycythemia vera, that is refractory or intolerant to hydroxyurea. And our second guest speaker, Dr. Prantar Chakrabarti from Kolkata, is going to lecture us on Post Specialization Engraftment in Clinical Haematology Lessons Learned. This webinar, as usual, is brought to you by Mumbai Haematology Group, supported by Novartis, Unipath, Lucien, and Nirvana Life Sciences, and very well managed by Perfect Square. I thank Team Novartis, Lucien, Unipath, and Nirvana, Mr. Yash, Mr. Kalpesh, and the team from Perfect Square, Executive Committee of Mumbai Haematology Group. Our guest speakers for the day, Dr. Akanksha Garg from Ahmedabad and Dr. Prantar Chakrabarti from Kolkata. All our discussants who are themselves very eminent hematologists as well as medical oncologists, and you participants for sparing a Saturday evening, morning, or afternoon from whichever part of the world you're logged in. Tomorrow, that is Sunday, 17th of August 2025 from 11:30 a.m. Indian Standard Time, and we have Dr. Mukesh M. Desai from Mumbai speaking to us on therapeutic armaments in inborn error of immunity. Let me introduce our discussions for the day, and they are displayed here in alphabetical order. I will pause for a while for you to have a look on all our discussions for the day. These are all eminent hematologists, hemato-oncologists, as well as medical oncologists across the country. So these are our discussions for the day. Now it's the time to introduce our guest speaker for the day. The first one we have with us no other than Dr. Akanksha Garg from Ahmedabad. We all know Dr. Akanksha Garg very well. She has been our regular attendee of Mumbai Haematology Group. No words to describe her, but it's my formal duty to describe and invite Dr. Akanksha Garg from Ahmedabad. Dr. Akanksha Garg is consultant hematologist and BMT physician at Zydus Hospitals and Zydus Cancer Center, Ahmedabad. She is ex-associate professor at Department of Medical Oncology Hematology from AIIMS, Jodhpur in the year 2022 to 2023. Ex-assistant professor, consultant hematologist and BMT physician at Department of Medical Oncology, GCRA, Ahmedabad from the year 2018 to 2022. She did MBBS from Maulana Azad Medical College from the year 2003 to 2009, followed by MD Pediatrics from Lady Hardinge Medical College from the year 2012 to 2019, followed by PDCC in Hemato-Oncology at prestigious Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow from the year 2013 to 2014, and then the DM in Clinical Haematology from the same institute in the year 2015 to 2018. She also completed her observership in adult stem cell transplant at Institut Gustave Roussy, France in the year December 2018. She also completed observership in pediatric stem cell transplant at Universität Klinikum, Germany, Jan 2020. She also did an observership in stem cell and cellular therapies at Department of Hematology from King's College Hospital, London, UK in November 2023. She has got following memberships starting from SIOP, PHO chapter, IAP, ISHBT, ISBMT, ESMO, and EHA. She has got numerous publications in peer-reviewed articles in both international as well as national journals. Her main areas of interest are stem cell transplantation, myeloma, lymphoma, acute myeloid leukemia, as well as hemoglobinopathies. Today she is with us once again, and she is going to lecture us on managing polycythemia vera, that is refractory or intolerant to hydroxyurea. Well, I stop over here. Over to you, Akanksha Garg.
Thank you, Dr. Amit, for the kind introduction, and I would like to thank Dr. M.B. Agarwal for giving me this opportunity. So I hope my slides are visible.
Yes, full screen mode, please.
Yeah, and I'm audible and you can see me, right? Okay, so today I will be discussing about the management of polycythemia vera, which is refractory or intolerant to hydroxyurea. So I will basically begin with the, the brief introduction of the disease. We all know that polycythemia vera is a chronic myeloproliferative neoplasm, which is driven by the JAK2 mutations in almost 95% of the cases. The symptoms include pruritus, fatigue, night sweats, and it is mainly characterized by an elevated hematocrit and the hemoglobin, as well as splenomegaly. Now, there are various risks associated with polycythemia, which includes thrombosis, which can occur in 26% of the cases, transformation to myelofibrosis in almost 16% cases, and AML in 4%. So our main treatment goals for these patients is to reduce the risk of thrombosis and hemorrhage, and also prevent the progression and control the symptoms so that we are basically able to improve the quality of life of these patients. In the whole lifetime, approximately 25% of the patients become intolerant to hydroxyurea or resistant to it. And I will be discussing further about it. But the hydroxyurea, which is the most commonly used cytoreductive agent in majority of the patients, it does not improve the symptoms or modify the disease. So, like I discussed, there are various symptoms that are present, which are associated with the reduction and the quality of life of the patients. And major problems associated are the thrombosis and the disease transformation. So, besides this, we also need to understand that we need to follow the patient's symptom burden, because even low risk patients, it has been shown that they do have the pronounced disease burden, which you can measure with the MPN SAF. That is basically your symptom burden scale, and that helps you to decide, what is the burden in the patient. Now, what about the JAK allele fraction? Is it associated with any higher risk of thrombosis or progression? So yes, this was a study which was published in Blood. And here it clearly showed that patients in PV who have the JAK2 allele fraction, which is increased, they are associated with having high WBC counts. There is a risk of venous thrombosis. So you can see that if the VAF is less than 50%, the risk is almost half as compared to patients who have very high allele frequency, which is more than 50%. In addition, these patients would also have incidence of splenomegaly. So patients who have a lower VAF would have lesser prevalence of splenomegaly, which was only 12% as compared to 90% in patients who had more than 50% JAK2V617F allele burden. And also the risk of progression to myelofibrosis is also higher. So you can see that patients who have low VAF, they would have almost nil incidence of secondary myelofibrosis, whereas in patients who have higher allele burden, the risk is much higher. Now, there are also certain mutations which are present in certain specific genes which are associated with the disease progression, mainly the U2AF1, which leads to an increased progression to myelofibrosis. If there are associated risks of association with IDH2 or RUNX1, as well as SRSF2. So these are some of the mutations that may be associated with increased progression to blast phase in these patients. And this was mainly shown by this retrospective two-center study. One was from the Mayo Clinic and the other one from Florence. So, and they basically used these markers to form the MIPS PV scale, which was part of the study. Now we quickly come on to the initial cytoreductive therapy. So I will briefly discuss how we treat these patients. So we all know that patients in the PV, they are diagnosed and then they are classified into whether having low risk disease or high risk, which depends on the age of the patient, as well as the history of thrombosis. So if the patient is less than 60 years and has no history of thrombosis, it would be classified as low risk. However, if the age is above 60 years or at any age, if the patient has had thrombosis, then the patient would be classified as a high risk PV patient. So the treatment differs. So in briefly, in the low risk patients, you would probably just give low dose aspirin as well as phlebotomy and monitor the patient. The patient continues to have symptoms, a high symptom burden, then you may have to add cytoreductive therapy in these patients. In the high-risk patients, besides the low-dose aspirin as well as phlebotomy, you have to give some form of cytoreductive therapy like hydroxyurea or interferon formulations, and accordingly you will monitor the response in these patients. And sometimes the patient may require second line treatments like ruxolitinib, some other interferon formulations, as well as there are certain new trials. So I'll be discussing about that. So before I begin, discussing the various trials for this particular topic, so we need to understand how we assess the response in the patients of polycythemia vera. So these are basically very clearly defined by the ELN 2013 guidelines, where patients can either have a complete remission if they have the hematocrit, which is maintained below 45% without any phlebotomies, platelet count of less than 4 lakh, or WBC count of less than 10. So all have to be there. And there should be absence of any hemorrhagic or thrombotic event. So if the patient is concurrently having these events in addition, then they would probably not be called as a complete remission. And in this particular criteria, they have also actually included the bone marrow criteria also, where the histological remission defined by presence of age-adjusted normocellularity and disappearance of trilineage hyperplasia. That is, we have the pyamylosis that should disappear after, the patient achieves complete remission, and there should be no increased fibrosis. And of course, we have criteria for the partial remission and no response. So these are clearly given. I won't discuss further. So we all talk about the strict hematocrit control in these patients. Why is it important? Very clearly stated by this particular study, which was the CYTO-PV study published way back in 2013. So here it was mainly a study of 365 patients with the polycythemia vera who were randomized to target hematocrit either to maintain below 45% or between 45 to 50%. And as per these Kaplan-Meier curves, you can see that patients who had the low hematocrit target, that is less than 45%, they are almost, you can see that it's a 100% probability of remaining event-free. Event-free meaning that cause of death from cardiovascular causes as well as thrombotic events were not seen when the hematocrit was maintained below 45%. Whereas patients who had the threshold of a higher hematocrit, that is 45% to 50%, they tended to have increased incidence of these events. So that's how we got the cutoff of 45% for maintaining the hematocrit in these patients. Then role of the low dose aspirin. So again, it has been seen that aspirin is associated with a reduction of cardiovascular events, adverse events in the patients with the polycythemia vera. And this was the ECLAP study, which was a double-blind randomized trial where patients of polycythemia vera who actually did not have any clear indication for aspirin, when they were given aspirin, then it was seen that as compared to the placebo, the survival of these patients which was better. They were free of MIs, cardiovascular events, and death from cardiovascular causes. That was seen to be better with the aspirin. And also the thrombosis-free survival was also better in patients who received aspirin. Now, why this role of hydroxyurea? So again, another study where the patients they were basically, it was the retrospective analysis of more than 1,000 patients where the patients were treated with either hydroxyurea or phlebotomy, and this was basically a subgroup analysis of the ECLAP prospective study only. And you can see here the patients who received the hydroxyurea, the cumulative mortality as well as the incidence of cardiovascular events was lower as compared to patients who were just receiving phlebotomy. So this was basically, for patients who were specifically in the high-risk PV. So that survival benefit was seen in that subgroup of patients. Now, we talked about the interferons. So again, the pegylated interferons, this was a study which was done by Quintas and his colleagues, where there were 43 patients with a median age of 53 years and having a long duration of polycythemia vera with a follow-up period of 42 months. And you can see here that the overall response rates for these patients were pretty good, reaching almost 80% for patients who were high-risk PV and they were receiving the interferons. And Interestingly, the median time to complete response was just 40 days for patients who were started on pegylated interferons in the high-risk groups. And complete molecular responses were also seen in 18% of the cases. Of course, drug-related treatment discontinuation because of the side effects were also there. So almost 20% of the patients did have the discontinuation because of the side effects. So this particular study actually, it tried to show that there is definitely a reduction in the polycythemia vera clone. There is a reduction in the JAK2 allele burden because of the use of pegylated interferons. So it may be causing a disease modification. So in addition to that, the clinical remissions could be demonstrated without the use of a cytoreductive therapy. There was a reduction, significant reduction in the vascular events and thrombotic risk. And whether there was a change in the disease natural history, that is the evolution of myelofibrosis or to AML or MDS, was probably it was hinted upon. Still, the clarity was not achieved via this study. Now, is pegylated interferon better than hydroxyurea? So this was the study, which was the MPD-RC 112 study. Now here, patients were high risk, that is more than 60 years, having thrombosis, hemorrhage, and a diagnosis of polycythemia less than 5 years, and treatment naive. They were randomized in a 1:1 fashion to either receive hydroxyurea or pegylated interferon. And here you can see that at the end of 12 months, you see on the right side, in both the ET patients also as well as polycythemia vera patients, there was not much difference in the attainment of CR at 12 months. So this study actually concluded that both hydroxyurea and pegylated interferon were almost, achieving equivalent CR rates at 12 months. So that was the, randomized study which was done. Then came the ropeg interferon, which was a novel monopegylated interferon alpha 2b, having a longer elimination half-life. And this was basically the landmark trials of the PROUD PV study and the continuation PV study. So these were phase 3 non-inferiority trials done in multiple European centers. Again, patients with polycythemia vera who had previously not received any interferon therapy, they were basically included. And these patients, it was important that they were treatment naive and they were requiring cytoreduction. So in these patients, they were randomized into either receiving the ropeg interferon or hydroxyurea. And the primary endpoints were a complete hematological response as well as a spleen response at 12 months. We have already seen what the CHR, it was the standard definition as per the ELN criteria. And the secondary endpoints were the molecular response, which was achieved, whether it was a partial response or complete response, reduction in the symptoms, improvement in the quality of life, as well as adverse events. So up till 12 months, it was the PROUD PV, and then the extension study, which was the continuation PV, was done in the same cohort of patients. And here are basically the results. So you can here it is important to note that up till 12 months. So if you see this, the orange one is for the hydroxyurea and the green curve is for the ropeg interferon. So up to 12 months, the responses are almost equivalent. There was not much difference. So either, for the achievement of the CHR or the molecular responses, here also you can see that the curves are meeting, as well as the JAK2 allele burden. But if we extended the use of ropeg interferon beyond the 12 months, that is the part of the continuation study where 36 months, you can see that there is a clear-cut difference in the curves. So the CHR rates were better maintained in the patients who achieved ropeg interferon, and the same was for the molecular responses as well as the JAK2 allele burden. So the allele burden continued to decrease in the ropeg interferon group, whereas in the hydroxyurea group, it was probably not able to sustain the reduction. So finally, I would now like to discuss that when do we switch the patients to second-line treatment? What are the indications? So we saw that, in the first line for the low risk, we use low dose aspirin. I showed the evidence for that, as well as phlebotomy. And in the high risk patients, we saw that, you use some sort of cytoreduction. Either you give hydroxyurea or you give interferons along with phlebotomy and low dose aspirin. But there are certain patients where you would require to change to the second line treatment. And what are the preferred agents for that? So this was another very interesting paper where they showed that at in a certain cohort of patients, the median follow-up was almost 7 years, and these patients were already on hydroxyurea. The time to development of resistance to hydroxyurea was a median of 6 years. And the time to intolerance to this therapy was almost 3.6 years. So many of these patients, after initial responses, they would again start developing either resistance or intolerance. So almost 25% of the patients during their whole course of treatment would develop these problems. So these are the patients where you would probably want to change therapy. And why was this of significance? Because it was shown in the same study that the probability of survival, it reduced in those patients who developed resistance, and the progression also, and the risk of death, it would be higher in the patients who were developing the resistance. So almost 5.6-fold increase in the risk of death and 6.8-fold increase in the risk of transformation. So this was only for the resistance. But for patients who were intolerant to hydroxyurea, that actually did not have any prognostic significance. So the patients who are resistant, they are mainly the patients who would require further treatment, and that needs to be addressed. How do we define the hydroxyurea resistance or intolerance? So again, very clearly defined by the ELN criteria. Any need for phlebotomy after 3 months of at least 2 grams per day of hydroxyurea. Any uncontrolled myeloproliferation after 3 months of 2 grams per day of hydroxyurea, or splenomegaly. So these are the 3 criteria which would define resistance. And if the patient is developing cytopenias at the lowest doses of hydroxyurea required, that would probably be either 250 milligram or 500 milligram per day. Or if the patient is having any non-hematological toxicity, such as, there are ulcers, either, the patient is having myelosuppression or any other adverse effects of hydroxyurea, then these last 2 criteria would be for the intolerance. So what options do we have for second line therapy? So broadly, the patient has previously received the hydroxyurea and has not been exposed to interferon, then that can be given. If the patient has previously received the interferons, then hydroxyurea can be tried in these patients. Then certain alkylating agents like busulfan and also this agent pipobroman, but again, these are less frequently used because of the toxicity associated with them. And then the main important agent is the ruxolitinib, which is the JAK-STAT inhibitor. This was approved in December 2014 for the patients who were having resistance or intolerance to hydroxyurea. So initial studies were the phase 2 studies of Ruxo in the advanced PV stage, where they were trying to decide what therapy would be, what dose of the treatment would be safe and efficacious at the same time. So in the part 1 study, they basically used 3 doses with 10 milligram BD, 25 milligram BD, and 50 milligram OD. And finally, the dose modifications were individualized. And in the part 2, it was the 10 milligram BD, which was mainly further studied upon. Now, important thing was that the time to the first response in these hydroxyurea resistant or intolerant patients was almost, it was the 97% of the response was achieved by week 24. And CR rates were 59%, and partial response rates were 38%. Then mainly in these patients, the randomized studies which were done comparing ruxolitinib versus standard therapy, those were the response studies. So in patients who had the hydroxyurea resistance or intolerance, they were randomized to either receiving ruxolitinib 10 milligram BD and then dose titrated accordingly to maintain the hematocrit, or standard therapy. So these are all patients who had intolerance and also had massive splenomegaly. And at week 32, that was the time point of evaluation. The primary analysis data cutoff was at week 48 or the treatment discontinuation. Crossover was allowed. So at the end of 32 weeks, as per this study, almost 77% of the patients, they met at least one criteria of the primary endpoint, and 91% of the patients who met the primary endpoint had a confirmed response by week 48. So you can see here that the responses in terms of reduction in the splenic volume, the hematocrit control was better seen with the ruxolitinib as compared to the best available treatment. Then what about the dosing? So majority of the patients, so almost by 32 weeks, 2/3 of the patients were able to tolerate doses of 15 milligram BD or even 10 mg BD. So both doses were well tolerated. And if there were any dose adjustments that were required, those were, the clinicians were able to do it in the first 8 weeks of treatment. So very less patients could tolerate the higher doses, which is 20 mg BD or 25 mg BD. Then the 80-week follow-up data, it actually showed that the patients, almost 92%, they achieved the primary endpoint, which was the both combination of the hematocrit control less than 45% and a spleen volume reduction of more than 35%. And individually, if you see, then hematocrit control was achieved in 89% of the patients and spleen reduction in 97% of the patients. Some of the patients did develop infections like the zoster reactivations on the ruxolitinib arm, as well as a few cases of non-melanomatous skin cancer were seen in the ruxolitinib. But other than that, the events of thrombosis, the disease progression, they were much lesser. You can see here in this table, they were lesser in the ruxolitinib arm as compared to the standard therapy. Then what about patients? The response to study was for those patients who did not have any splenomegaly. So patients with the resistance or intolerance to hydroxyurea, but without having splenomegaly. So was there any difference, with the use of ruxolitinib as compared to best available treatment? So here again, you can see that the hematocrit control was significantly better in the ruxolitinib arm as compared to the BAT, and the resolution of the symptoms. Of course, here we don't have the splenic volume to be discussed because these were patients who did not have any splenomegaly, but the complete hematologic response as well as a complete resolution of the symptoms and, in terms of the NPN SAF symptom scale was much better with the ruxolitinib as compared to the BAT. Now, after these studies, the further trial that was done was the MAGIC PV study. So this was mainly, what they were trying to see was whether the patients do have any molecular responses also with the ruxolitinib or not. So again, patients with high-risk PV with resistance or intolerance to hydroxyurea, they were risk stratified and then either randomized to receiving ruxolitinib or best available treatment. And here, in these patients, you can see that the event-free survival as well as the molecular responses, the incidence of thrombotic events, and overall responses, they were better with the ruxolitinib arm as compared to the best available therapy. So there was, of course, some effect on the EFS also with the use of ruxolitinib, and molecular responses also. And it basically correlated with the molecular responses in these patients. This is also a study which is quite interesting, where this is the low PV study for patients with low risk PV, where if they were developing any adverse events or side effects of interferons, in those patients, what happened was that the patients, this was basically in the patients where they were either receiving standard treatment, which was phlebotomy or low dose aspirin, vis-a-vis use of ropeg interferon plus this standard therapy. So was there any advantage of adding ropeg interferon in these particular patients? And here they saw that the composite endpoint of hematocrit control of less than 45%, as well as the lack of disease progression in the form of thrombocytosis, leukocytosis, or major vascular or bleeding complications, that was shown to be much better in case of patients who were receiving low-peg interferon as compared to standard therapy. And disease progression was not seen in any of the patients, whereas 8% of patients did have some progression on the standard treatment. Now, because the patients on pegylated interferon, they can have those side effects. Then this was the combi study where the patients, they were given a combination of pegylated interferon as well as ruxolitinib. So this included both patients of polycythemia vera as well as myelofibrosis. This was a phase 2 study, mainly done in Denmark. And the rationale was mainly that to control the inflammatory side effects. So ruxolitinib would act like an anti-inflammatory agent, and that would help in reducing the inflammatory toxicities of the interferon. And here again, the primary endpoints were of the achievement of the CR. So almost in the myelofibrosis group, 44% achieved remission and 28% had CR. And in the PV groups, 31% had remission and with 9% having CR. And in these patients, what they saw was that there was also a better reduction in the JAK2 allele burden. Now, coming on to the side effects of these agents. So we know that all the three agents, which are the main pillars of treatment of polycythemia vera, interferons, hydroxyurea, ruxolitinib, they do have these certain side effects. And we as clinicians and hematologists, we should be aware of these side effects in the patients. And the major ones for, ruxolitinib are, the risk of active infections. We have seen patients having tuberculosis reactivations, herpes, and, zoster reactivations are definitely seen. So these are, some of the effects that we need to be carefully monitoring in these patients when they are on these therapies. And of course, for hydroxyurea, leg and mouth ulcers can be seen. Interferons, of course, the inflammatory toxicities, myalgia, certain autoimmune disorders, hypothyroidism, those are some of the notable side effects. For the interferons, this is just a table where, it is just highlighting what are the various doses of both the pegylated and the low-peg interferon. Of course, these are not available in India, but we should be aware of that. So pegylated interferon started at 45 microgram per week, and then the dose is increased every 2 weeks by the same dose, 45 microgram, till a maximum of 180 microgram. And for low-peg interferon, it is started at 100. The dose increment is 50 microgram every 2 weeks, till a maximum dose of 500 microgram every 2 weeks. And these are the guidelines where, how you would do the dose adjustments according to the potential toxicities, and how do you monitor during the treatment. So what about the ruxolitinib? Again, we know that the starting dose is 10 milligram BD, and we can go up to a maximum dose of 25 milligram BD. However, I don't think that majority of these patients tolerate that much dose. That is the standard. So you start at 10 mg, and according to the various CBC parameters as well as the spleen size, you may go up to 25 milligram BD. And it is important that if the hemoglobin falls below 8 gram, or the platelet falls below 50,000, or the ANC is below 1,000, the patient's dose needs to be interrupted, and then you can further, repeat the dosing after 2 weeks time. The CBC testing can be done after 2 weeks, and accordingly adjust the dose. So CBC monitoring, very important, and also monitoring for the infections. That is extremely important in these patients. So similarly, this is just a continuation of the same. These are available everywhere, so we can always refer to these guidelines. So last part of the talk, what about the investigational strategies which are there? So most important in this aspect in the polycythemia vera field is the use of the hepcidin mimetics. So we have the agent which is rusfertide. So basically, this is a injectable drug which is given subcutaneously, it is a hepcidin mimetic. So what it really does is that it basically binds to the ferroportin and it prevents the efflux of the iron from the cells into the blood. So it actually leads to a sort of a functional iron deficiency and helps in regulating the erythropoiesis. So excess erythropoiesis is prevented with the use of this agent. And main study, the initial one was the REVIVE study, where this was a, a 3-part study. Initial was the dose optimization study, then the withdrawal part, and then the open label extension. And the primary endpoint of this particular study was the proportion of the responders during the randomized withdrawal period, which was defined as a, response was defined again as hematocrit control less than 45% without the use of therapeutic phlebotomy and completed 12 weeks of treatment. So that was the endpoint. And of course, in these patients, the response rates were very good. Almost 69.2% of the patients had good responses in terms of, independence from therapeutic phlebotomy, as well as a hematocrit control of less than 45%. And the various, these patients, they achieved this at, quite early during the treatment. In terms of safety also, not much adverse events were noted except for mild itching as well as fatigue and inactivity, which was seen in a proportion of the patients. And most of the patients, they just had slight injection site reactions. Other than that, it was well tolerated. The ongoing study is the randomized VERIFY trial, where again, here the patients are randomized to receiving rusfertide versus the placebo. And this is basically studying the proportion of patients achieving response at week 20 to 32. And the secondary endpoints are the number of phlebotomies as well as hematocrit control of less than 45%. Many other agents are also there, like certain HDAC inhibitors. These are all very complicated names, but they are all in trials. And hopefully, with the use of these agents, would be we would have more drugs available to us for the management of these cases of polycythemia vera. So the take-home message from my talk is that the resistance or intolerance to hydroxyurea occurs almost in 20 to 25% of the patients. The resistance is mainly the poor prognostic group of the patients. The intolerance, it does not have any prognostic significance. Patients with resistance, they would have incidence of cardiovascular events as well as the risk of progression, and hence we need to address these particular cases. Ruxolitinib is now the key second-line therapy for patients having hydroxyurea resistance and intolerance. Long-term treatment is possible, and along with dose modifications, we have very clear-cut guidelines available. Ropeg interferon may be showing a disease-modifying potential, where we saw the MAGIC PV study where there was a good molecular response in the patients. However, now at present, there is no such treatment which has been shown to alter the natural history of the disease or reduce the rate of transformation. So maybe with ropeg interferon, it may be there, but still not yet, properly documented. And there are multiple newer agents that are available, and that would help in, personalized therapy for these particular patients. And of course, lesser side effects that would be there for the patients. So thank you so much for your kind attention.
Thank you, Dr. Akanksha, for a wonderful talk. Almost complete, very crystal clear. Thank you so much.
Thank you.
And I now request all our discussants to please put the hand raise sign so that we can start our question session with Dr. Akanksha. Yeah. So Dr. Kritika Goyal, your question, please.
Hi, Dr. Akanksha. Thank you for this wonderful talk. I just wanted to know your experience regarding the use of pegylated interferon. Are you using it in your practice, and what are the side effects that you have to monitor? Because in our practice, we haven't used it yet.
So yes, unfortunately, the availability of interferon is not there. I mean, I remember when I was doing my training, we did have even the conventional interferon was easily available. But now the pegylated and especially, I mean, raw peg interferon, you can, import it, but it is very expensive. The cost runs in lakhs, and giving it every 2 weeks is very difficult. So in that aspect, at least in our country, we do have a problem using the interferon. But in some of the cases, I have also used the interferon alpha 2b. So that the patients actually they don't tolerate it well, and according to my experience, it has not been too effective in controlling the hematocrit. So because of the side effects, the patients usually don't want to continue it, and especially if it's a non-pegylated form, it has to be given every 3 times in a week. So it's very difficult to counsel the patient and also ensure that they are compliant with that drug. So I haven't used pegylated, but the non-pegylated one, these are some of the challenges that I faced while using it in some of the patients.
Right. Thank you.
Thank you.
Thank you, ma'am. One question has come from the audience. This is from Dr. Prashul.
Yeah.
What is your take on using twice daily versus once daily aspirin?
So I don't use twice daily aspirin. So I'm mostly using the once a day dose of aspirin. That too also, majority of the cases I'm using 75 milligram only. If it's a high risk patient, I would use 75 milligram along with the hydroxyurea. And of course, it's important that the high risk patients, the initial few weeks, you need to do a phlebotomy in those patients so that you can have a better control on the hematocrit. But I haven't used twice daily aspirin in the patients.
Thank you. There are certain questions which is related to the deep vein thrombosis and the patient developing polycythemia. Number one, if the patient has already developed deep vein thrombosis, history of deep vein thrombosis on hydroxyurea and aspirin, so would be your drug of choice, whether LMWH or DOAC, number one. And if you're putting the patient on anticoagulation, whether you will still continue with aspirin prophylaxis.
So if the patient has a venous thrombosis, in most of those cases, if I'm using an anticoagulation, so in the acute phase, I would prefer an LMWH. And first, if I can document that there is a reduction in the thrombosis or there's a recanalization, then I can safely, switch those patients onto a DOAC. If it's a venous thrombosis, I usually then don't give the aspirin because these patients can be at a higher risk of bleeding. But of course, if it's the arterial thrombosis, then I would still want to give, continue the aspirin at least in those patients. But for the venous, I think I may stop the aspirin and just continue the anticoagulation. And of course, if it's, it has to be given lifelong because they will always be at risk of, developing recurrence if we stop the anticoagulation.
So DOAC versus VKA?
So I would prefer using a DOAC. Although, I mean, I'm sure, many a times DOACs may not be that effective in controlling in providing the anticoagulation, but my preference is DOAC. Maybe it may be different for other hematologists, but I prefer DOAC.
Thank you. Any situation where you will prefer thrombolytics in case of polycythemia?
So yeah, if it's a acute thrombosis and life-threatening, so yeah, that can be used. That is not a contraindication, I think, unless if they have any other issues which are there. But personally, I have not faced any case where there was a need for thrombolytic. So, but I mean, according to the situation, it may be given. So that is not a problem.
Thank you. There is a question from Dr. Mindogas. In real life, resistance to hydroxyurea often is overlapping with polycythemia progression to secondary myelofibrosis. Is there any place for bone marrow biopsy and cytogenetics or any place for transplant consideration?
So per se in polycythemia vera, I mean, if you feel that, it's a long term, you've been using the hydroxyurea, patient is having an increase in the counts. So I think one very important thing is the presence of a leukoerythroblastic picture in the PS. So if you feel that, there is occurrence of NRBCs, or, there is left shift is there, then in those patients, you may consider doing a bone marrow. In terms of, the use of transplantation. So if it's a secondary, post PV, MF or AML. So for the AML, of course, if the patient is fit enough, then we would probably, counsel them for a transplant. But for a secondary MF, it depends, if it's just, in the initial phases and has not gone into advanced phase, I would probably, not go in for a transplant. I would not counsel the patient for transplant unless if the patient has transformed into the advanced phases or has gone into AM.
Thank you. Another question is from Dr. Mansa. She has got two questions. What is your experience about the pediatric patients? Is it same for the adult patients? What is their overall outcome? And any predictors for resistance to hydroxyurea?
So again, in the pediatric, I think polycythemia vera would not be, it's basically a disease of the middle-aged people. So in pediatric, I have not seen any case. I'm sure, the question is regarding polycythemia vera, right? Not secondary.
Polycythemia.
So not vera, it could be secondary also. So for secondary, we don't use, hydroxyurea. We need to find the cause for these patients. By they may be having other causes like congenital polycythemia. So we need to, or methemoglobinemia. So all those causes for secondary erythrocytosis, that has to be looked into. So, but in cases of secondary polycythemia, there is no role of using hydroxyurea. And what was the second question?
And for primary polycythemia in pediatrics?
So yes, so even for congenital polycythemia, in those cases, basically, the cutoff for the hematocrit is different. So it is not 45%. Usually keep it at 52 to 54. And if the patient is having above that, then you would probably go for a phlebotomy. But there's no role of cytoreduction. You can give aspirin, that is fine, but no role of cytoreduction in these patients. The target hematocrit is different for these patients.
Thank you. And any predictors for resistance to hydroxyurea?
So, not aware of that. But I guess probably patients who are having these U2AF1 and the other mutations, they may be having resistance because they inherently, there is a risk of progression. So maybe in those cases, you may have to, watch out and monitor those patients closely. But other than that, I'm not aware of any predictors for hydroxyurea resistance.
Thank you. Dr. Gopinathan, your question.
Good evening, ma'am. My question is like, what do you use pentoxifillin in polycythemia vera patients?
No, I haven't used that.
Yeah. Ma'am, right now I have a patient who's like 60 years old.
Okay.
Hemoglobin is 18.5, 30,000 of WBCs and platelets for around 6 lakhs. But then he had very vague presentation, like he was fully irritable. He presented almost like an encephalopathic patient.
Okay.
But obviously, other cause of thrombosis, infection, nothing we could make out. But suddenly, when we did, obviously we did a marrow. Marrow was showing panmyelosis, and when we just managed him with hydration, hydroxyurea, these things got better. But he continues to have some microcirculatory disturbances in the form of memory deficit, some kind of erythromelalgia. So in these particular subset of patients, do we have a role of pentoxifillin?
So I'm not aware of it, but maybe I'll have to read the literature. I'm really not sorry, but I don't have much information on that. Have you done any, have you done any, like an NGS panel for this particular patient? And are you planning to use ruxolitinib for this?
Yeah, he was ruxolitinib patient. Since he was responding to hydria, I just thought like we will just keep him on hydria.
Continuing to have these, if you feel that there is some microthrombosis that is ongoing, that is actually, as per the definition, it could be a reason for, it could be a marker for resistance, So
Okay.
I think it would be,
Right.
it would be better that you shift to ruxolitinib. Of course, interferon not available, but I think Ruxo would help because it has been shown that, it improves the thrombosis-free survival. So it would be a good idea for, to shift this patient to Ruxo as compared to hydroxyurea.
Hydroxyurea. Yeah. The only vague feature that I note in this patient is even at the lowest hemoglobin, as low as 15, 14,
Yeah.
he is having these kind of persistent microcirculatory disturbance. So that's what I found it quite different in this patient compared to the other routine PVs that we see. So
Have you
that's
done
why I just wanted
any
to.
like mutation panel or something? Although it doesn't have much role, but have you done anything? And what about the spleen? Has it regressed on?
Yeah, spleen is just 14 centimeter, ma'am. Just not so great. On the entire span is 14 centimeter, maybe hardly 1 to 1.5 centimeter on palpation clinically.
Okay.
So yeah.
Yeah, but even with the as per the response to even these patients, it would be a good idea to maybe switch him to Ruxo at a lower dose and see if those those symptoms subside, because that shows that maybe he is still prone to these thrombotic events, or and does he have any cardiovascular risk factors?
He has a borderline hyperlipidemia, ma'am. That's it. Like very well controlled. Other than that, no hypertension, no diabetes mellitus and all that. Like this, just a borderline hyperlipidemia, which is very well medically managed. Rather than the hemoglobin number, I find very difficult to manage this microcirculatory disturbance in this patient. So that's why I just thought is there a
He's
low
above 60 years, right?
He's above 60, ma'am. He's above 60.
So, it's a good, you can use that, but sometimes, hydroxyurea may not be the best cytoreduction because we don't have access to interferon. Then that's what we need to, just see and accordingly plan. You may
Sure,
try.
sure.
I may be wrong, but I think you can give it a try and see.
Should I add something?
Yes.
This microvascular symptoms or the erythromelalgia, there was one talk which was already taken up just last few months back. And the speaker had told that aspirin would be the drug of choice, maybe at a dose of 150 milligram once daily. Regarding the pentoxifylline, there are few case reports. If your hydroxyurea doesn't work, or if your aspirin along with it doesn't work, you may add up. Some few case reports are there. That is, a dose is about 400 milligram twice daily. But data is very limited. But in some patients, it has worked. So in those patients, the hydroxyurea and aspirin has not worked in your patient, you may add as an adjunct to hydroxyurea or aspirin. But aspirin to be increase the dose of 150 milligram. If that is also not working, then you may add a pentoxifylline 400 milligram twice daily. But these are only some limited data, and the case reports are there, or just as an adjunct to hydroxyurea and aspirin.
Okay. Thank you, sir. Sir, aspirin it's better to give it as once daily or like twice daily,
So in erythromelalgia, what the speaker had already spoken before was that there in USA, the dose is always 80 mg per day. But our Indian tablets are available as 75 milligram per day. So what they say basically is about the half-life. So it's about 12 hourly. So when the patient is manifesting microvascular complications, what has worked is basically if you give twice daily, 150 milligram per day, once a day is not advisable. Better to go for 75 milligram in two divided doses. So 75 milligram. So that has worked more for the patients who have got erythromelalgia. This is what the speaker has said, but I have no experience about it. So just yeah.
Maybe in the future talks I'll use and then tell this experience.
So I think hydroxyurea plus 75 milligram twice daily of aspirin plus pentoxifylline 400 milligram twice daily. I think that should be the way to go.
Yeah. Thank you, ma'am. Thank you, sir.
Thank you. There is one question from Dr. Prashun once again. In your routine practice, do you regularly do NGS in patients with polycythemia? Number one, since the co-occurrence of some other mutations may impact the prognosis.
So as of now, no. I mean, that was basically part of the trial. So in my own practice, I'm not doing those mutations.
Thank you. Another question is from Dr. Sui Louis 10. Does hydroxy reduce the pruritus in PV?
So yes, I mean, hydroxyurea is known to improve the symptoms, but in terms of so of course, because there would be an improvement in the counts and the hematocrit. So all these features of erythromelalgia would definitely decrease in the patients, but symptom control is there. So that is documented. So definitely, I mean, if you use that, it will, patients do say that, then there is an improvement in the symptoms if they are responding to hydroxyurea.
So Dr. Akasha, may I ask you one question? What are you using for pruritus in hydroxyurea? In patients with polycythemia, apart from hydroxyurea?
So I'm usually giving Atrax to these patients.
Okay.
And usually, I mean, other than that, I think I've not had any major complaints of pruritus in the patients. Once you do the phlebotomy and the hematocrit comes down, the symptoms improve. So it's only for the initial few weeks till they have we achieve the target hematocrit. What about you? Are you using something?
Some patients who have got intractable pruritus, though the hematocrit is less than 45, they still have this pruritus business.
Mm.
I think for them, I have tried using paroxetine also in some patients, and they really worked at a dose of 12.5 mg per
Okay.
day. Another question is whether ruxolitinib is better or interferon is better out of the two.
So, as per the trials, there hasn't been any head-to-head trial for the Ruxo versus the interferon. So it has always been either Ruxo versus BAT, but no head-to-head trial between the two. So, Ruxo is usually, I mean, it is used as a second-line treatment. There are some studies, the Ruxo Beat was one study where they have used it in the front line, and that had been shown to have a good outcome. But still, as per the current guidelines, it has to be used as a second line. So, if you're using ruxolitinib, whether to choose a pegylated interferon or a ruxolitinib, it is up to you. There is no head-to-head trial. Yeah, there was a combination trial which was done where they used both, Ruxo with pegylated interferon for, just to balance out the inflammatory side effects of interferons. But there is no head-to-head trial comparing the two.
Thank you. Another question is from Dr. Wang Hung Lee. When is phlebotomy needed in patients with secondary polycythemia who are presenting with acute ischemic stroke?
So for the patients with the, if the patient has developed a stroke and the hematocrit is, above 55 or 56, then of course, I mean, you need to maintain in these patients, the hematocrit has to be below 52 to 54, that is the range. So you maintain that. If it is above that, then you do a phlebotomy. And of course, for managing the stroke, you have to do your supportive treatment and the other modalities that we use. But I think 52 to 54 would be the cutoff for a secondary polycythemia. And usually these patients, I mean, secondary, I have not seen any case of, unless the hematocrit is much higher. But if it is above, if it's going up to 60, of course, then in those cases, you would have to do a phlebotomy also. Because the cutoff, that is why the cutoff has been kept as a 52 to 54, because at that level, usually these patients will not have such life-threatening symptoms.
Thank you. Another question is from Dr. Raghavendra Rajesh Workar. Have you tried the combination of hydroxyurea plus ruxolitinib in patients with polycythemia rubra vera?
No, I have not used personally.
Or any study which has undertaken combination of both hydroxyurea plus?
So not for hydroxyurea. I mean, whatever literature I have reviewed, so there was no combination of HU with ruxolitinib. So it has always been, except for the ROPEC plus Ruxo study, which was the Combi PV study, not for the combination of hydroxyurea with Ruxo. I think if you use ruxolitinib, then probably hydroxyurea may not be required.
True. Another question is from Dr. Wang Hung Lee. Any evidence of first-line use of ruxolitinib in PV? First line.
Yeah, so there was a Ruxo-Beat study where they have shown that even in frontline with advanced PV cases, ruxolitinib had a positive impact. There was a better thrombosis, free survival, as well as improvement, symptom improvement, and hematocrit control. But at present, it is not. I mean, the preferable first line is always hydroxyurea with the this thing. And for the intolerant cases, you may switch to ruxolitinib.
Thank you. Another question is related to, again, persistent pruritus, which is not responding to hydroxyurea despite regressing and responding blood counts, but pruritus is not responding. Is there a case that we must switch over from hydroxyurea to ruxolitinib for this business of persistent pruritus?
So I think, again, it is always said that these microvascular symptoms, if they are still persisting, despite using hydroxyurea, and the patient, it is significantly affecting the daily work routine of the patient, then you may consider switching to ruxolitinib for symptom control. So I think if it is not being controlled on hydroxyurea, till the dose, maximum dose which is tolerated by the patient, then it is I think probably a good idea to switch the patient to ruxolitinib.
Thank you. Another question is related to pregnancy with polycythemia vera. How do you manage?
So patients usually, if the patient becomes pregnant and has been diagnosed with polycythemia vera, so one would be whether the patient has developed any thrombosis earlier or not. So if the patient has had a previous thrombosis, then it would be better to give prophylactic anticoagulation in the patients. If there was no previous thrombosis, then just give the aspirin. Of course, hydroxyurea we don't recommend. So it is very difficult to, if they are able to tolerate the the interferon, then you may use the interferon for these patients according to the availability. But hydroxyurea need not be used. Therapeutic phlebotomies can be done in the patient, and usually in the second or the third trimester, because of the the volume expansion, most of the times I think the patients will not have a difficulty in controlling the hematocrit below 45. So but in the first and the early part of second trimester, you may have to use this, and of course use the aspirin, that is fine. And yeah, but these patients, I mean, whatever experience that I have had, it is very difficult for these patients to even conceive, because there is always risk of microvascular thrombosis, and risk of IUD is always there in the patients. Many a times they are not able to conceive also properly, because or they have early abortions also. So that is something which needs to be addressed. So yes, I think that is probably how you would go about managing.
Thank you. There is one question related to a patient who has polycythemia vera, JAK2 positive. Hematocrit is well maintained below 45. Patient still has hyperviscosity symptoms in the form of headache and heaviness of the head. So what should be the cutoff of hematocrit in such cases where the patient maintaining between hematocrit less than 45 on hydroxyurea has got all the persistent symptoms such as headache as well as hyperviscosity symptoms or heaviness of the head?
So again, I think if the patient is still, I mean, it is your clinical judgment. If you feel that yes, the patient is still having these symptoms, and you would probably want to switch the patient to a second line therapy. So I don't think that we need to just continue, because below 45, if you go below 45 and like there's no other cutoff other than 45. I don't think that there's any lower cutoff that you need to maintain in these patients. But if the patient continues to have that, then you probably just change your to a second line treatment for symptom reduction. So ruxolitinib in those patients.
Thank you. So repeated phlebotomies have led to even iron deficiencies in many of the patients, and patients are symptomatic for it. Do you go for replacement of iron in such patients, or?
So the cutoff, I think, for ferritin should be maintained below 50, I think 50 nanogram. So if the patient is having, so of course, I mean, usually in these patients, the phlebotomy, we usually don't, we want to keep the ferritin below that level. If it is above that, then of course you need to continue the phlebotomy in these patients. But I have not supplemented patients because, you would stop the phlebotomy then and there once it goes below 45 or the hematocrit goes below 45, then there is no need to do any maintenance phlebotomies in these patients. And again, of course, recurrent phlebotomies would lead to further iron deficiency, but ferritin has to be maintained below 50.
So if it is less than 50, would you like to replace with iron?
No, unless the patient is having symptoms. Otherwise, I would not.
Okay. Another question is from Dr. Raghavendra Rajeshwarkar. What is the maximum volume of phlebotomy you can do? Frequency and other details.
So I think maximum volume is 500 ml. So usually in my practice, I'm doing between 300 to 350 ml, but I think 500 is maximum tolerated. And frequency, I mean, initially, even weekly the weekly phlebotomies can be done. No, I think twice weekly, that would be only in a case of any emergency where you need reduction. If the hematocrit goes above 60 or something, then you would probably do that. But I think up till maximum of 500 ml, and in a stable patient, weekly phlebotomy, still you have the reduction.
Thank you. Any role of erythrophoresis? Erythrophoresis?
Erythrophoresis?
So by not the manual one, remove it by the exchange. What we are doing, the red cell exchange. Any role of that?
No, I don't think so. I think phlebotomy would be sufficient. I'm not aware of that.
Fine. So that's all. Yeah. Anybody has any other question? Well, so pregnancy is all fine. I think there are no more raising signs. Well, thank you so much, Dr. Akanksha, for that wonderful talk, wonderful discussion as always. Always good to hear to you. You have very complete knowledge, and always when you speak, your way of lecturing is perfect and almost complete.
Thank you.
Thank you so much for the beautiful lecture, wonderful discussion. And I also thank all our discussants. We have our second lecture starting at 7 p.m. Dr. Pranta Chakraborty is yet to join. So, Mr. Kalpesh, what should we do? We should wait for 20 minutes, or should we log in again back after 20 minutes? So I think we'll log in back after 20 minutes. So our next lectures will start at 7 p.m. By Dr. Pranta Chakraborty. Right. Thank you.
Thank you.
Well, so welcome back after a short break. We go with the second guest speaker. We have no other than Professor Dr. Prantal Chakrabarti from Kolkata. He was my mentor, my teacher, and I always welcome him and I respect him like anything. Thank you, sir, for being with us today. And the topic you have chosen is marvelous. The topic is, let me first of all introduce Professor Dr. Prantal Chakrabarti to all of you. He's MD Medicine, DNB Medicine, DM Clinical Haematology. Currently, is the Honorary Professor, Health and Wellness at Sri Sri University, Consultant Hematologist, Zoho Corporation, Founder, Shoe Mentor Academy, Mastermind for CyberneticCare.com, ex-professor and head, Hematology, NRS Medical College, Kolkata. Today, he is going to lecture us on a very beautiful and a marvelous topic, which I think no one has heard about it. And it's about Post Specialization Engraftment in Clinical Haematology, the lessons learnt. Well, thank you so much. I stop over here. Over to you, sir. I would also like to request all our discussants who are there over here, as well as the audience, is going to show some 2 Slido decks and will with the QR code, and which you need to open it from your another device, that is mobile. And once you log in from that, you'll be able to answer his questions from the next Slido deck, which will be open on your another device, that is your mobile phone. Well, sir, with all this, you may proceed, sir.
Thank you, Amit, for those kind words. And thanks to Mumbai Hematology Group for giving me this opportunity to interact on something which is close to my heart. But more than that, I always try to share my mistakes. So this is a mistake sharing session. Before that, as Amit has told you, you may please join by scanning this QR code. Or if you already have your Slido app, you can just give the number. Don't worry, no username, password, nothing is required. You do not even need to download the app. It will come in your browser also. And when I show the question, that particular question will come. Your answers will always be anonymous. So don't worry that you will be identified as someone who is hungry for money or something like that. So don't worry, all anonymous. I just want to know the pattern or the thinking or the mindset of my audience. So as you all know, it has been proven long back that engraftment is the most important variable for a better overall survival after stem cell transplant, right? This has been proven, this has been published almost 10 years back. And I felt that engraftment is the most important variable for a better overall survival after your specialization. So there might be some people in the audience who are thinking of specializing, who have not specialized, no problem. But I will start my journey after you complete your specialization. But before that, here is my first question. So I hope you can see it. I'll give you around 20 seconds. You can choose anyone, right? You want to specialize, or you have specialized because you wanted to learn more, or you wanted to earn more, or you wanted to become a celebrity or a rock star, or you wanted to fulfill someone else's wish. Might be your spouse, might be your parents, might be your peers or your teacher. Or you wanted to enjoy studentship for some more time, right? So you don't want to take responsibilities. You don't want to, get in. Let me do a specialization. And, in government service, sometimes people do specialization just to avoid a rural posting, because the super specialty departments will not be there in the rural health centers and district hospitals. So they do it. Please be honest enough. As I told you, these are all anonymously recorded. So I will never even know who all has answered. I can see till now 9 people have answered. I'll wait for 10 seconds more. Because if I get 10 answers, that would be great. I know for the first time, you need some time. But for the next question, which will come after 15 minutes, it will be easier for you. I can guarantee you that. Okay, great. So 10 people have replied. And let me see who are the majority. Oh, lovely. Look at the distribution. So to learn more, 30%, to earn more, 20%, to fulfill someone's wish, 20%, enjoy a studentship for some more time, 20%. One person has even said to avoid rural posting, but no one wanted to become a celebrity. Okay. So that's a good mindset. I think learning is the top priority. And let me start from here. Now, this is what happens when you complete your specialization, whatever be the degree, DM, DNB, fellowship, or even observership, you feel like you are on cloud moon. And this box, this Alibaba's box, is slowly opening for you, right? I don't know about others, but I also had a similar feeling. So let us welcome you to your journey. And why we need to have this conversation? Because of some kind of navigation, of guiding you through the complex landscape of hematology practice in India's diverse healthcare sectors. And there is some amount of balance which is required, right? Critical balance between professional excellence, ethical practice, and personal well-being, which we tend to neglect at times. And how do you prepare, how to provide you practical tools for sustainable career growth in a rapidly evolving medical landscape? Medical training has prepared us for clinical challenges, difficult cases, but it rarely addresses how to build a fulfilling, ethical, and sustainable career. I'll try to bridge that gap today. You will judge whether I have been able to do it or not. So, why is India unique? Because it has a lot of challenges, but I think every challenge is an opportunity. You have shortage of healthcare workforce, limited access to healthcare services, high disease burden, even rare diseases are not rare, high out-of-pocket spending, and we are having now government health programs to correct this, right? So let me talk of the vicious cycle which ails Indian medical practice. We have less spending on healthcare infrastructure. Still, it is around 3% only, and that includes all the 5-star hospitals. There's a poverty, illiteracy, and poor sanitization in spite of Swachh Bharat campaign. There's a delayed diagnosis because of lack of expertise, inadequate lab support. So what happens is people come to us late. So what was, say, stage 1 Hodgkin's come to us at stage 4. And then we use more of our healthcare resources. And there's increased mortality because of excessive toxicity and inadequate supportive care. And we use more resources with poor outcomes. And then the circle continues like this. And as a physician in India, let alone a hematologist, we face certain challenges because we are supposed to provide standard of care to affording patients. We have to provide compromised but effective care to less affording patients. And the care could be hampered by patient variables like financial, literacy, even non-compliance, where mental health can be an issue also. Then physician come hospital variables like diagnostics I've already spoken about, standardization of the laboratory, availability of the drugs, the quality of the drugs. And then you can be a god one day and you can be a devil one day, right? Now, if I look at the hematology landscape in India in 2025, it presents certain distinct challenges. There's a high prevalence of hemoglobinopathies, though I think most of the trainees and super specialists do not think it is sexy enough, like thalassemia, hemophilia, sickle cell. There's a growing burden of hematological malignancies, significant urban-rural disparities in access to care, resource constraints affecting diagnostic and treatment options, traditional medicine practices, they might go there, they might come back to you later. So as a hematologist in India, you're not just treating diseases, right? You are navigating a complex pathway of cultural, economic, and systemic complexities, which are unique to our country. So I think you should take it as an opportunity rather than a challenge. But we are in a VUCA world, right? It's not that VUCA of Hindi. It's volatile, uncertain, complex, ambiguous, which has come into the light post-COVID. So how well can you predict the results of your actions, and how much do you know about the situation? If you plot them, so complexity would be you cannot predict. There are multiple key decision factors. Volatility is you cannot predict and you do not know much. So rapid, unexpected challenges. Ambiguity is there are too many unknown unknowns, and uncertainty is these are known unknowns, but you do not know when the situation will change. So, how do you interpret VUCA in hematology? Rapid changes in healthcare policies, insurance frameworks, treatment protocols. What was said to be the standard of care, now it is said no more. And then you have, Ayushman Bharat, you have CGHS, and then you have insurance companies who keep on changing their policies. What is uncertain is unclear future of the healthcare models. We'll do a ramp work on the models. Technology integration, disease patterns. There's a complex intellect system of patient, family, hospital, insurer, and regulator, including National Medical Commission. And ambiguity. You cannot interpret the clinical data. Even ChatGPT and Gemini fail sometimes. Patient needs and what is the optimal approach? How do you optimize it? So the Indian healthcare system actually exemplifies the VUCA with its mix of traditional modern medicine, public-private providers, and rapid policy evolution. No, it is not in your hand, right? You cannot control it. But you can counter VUCA with another VUCA. What is that VUCA? That is vision. You have to develop a clear purpose and direction despite this volatility. Set 3 to 5 year goals with flexibility. In the chat box, you can tell me that when a pilot starts the flight path, he or she is given a flight path. Can you tell me what percentage of that flight path they maintain while flying? Yeah. Does anyone know? Well, let me tell you, the flight path is adhered in 0% cases because constantly they have to change it, right? So you have to have an understanding to invest in continuous learning to reduce the uncertainty, and you have to build networks across specialties and sectors. What is the C here? Instead of complexity, you should have clarity. Through systems thinking, develop frameworks for decision making, and you should be agile, not ambiguous. Remain adaptable in the face of ambiguity. Experiment with small initiatives, right? That is how the Japanese do it before major changes. Now, if you go to the Maslow's need hierarchy for every human, there's a pyramid of your needs. The most important baseline is physiological need. Then it's the safety. Then it's a question of love and belonging. And then it's a question of your esteem, which you might lose in certain models. And on top sits self-actualization. That means you need to be recognized for whatever little you do for a patient, for your family, for your society. Now, where do you have to engraft, right? You have to engraft in so many places. Workplace, family. This is difficult, let me tell you. And if you have started your family after your specialization in terms of marriage, it is more difficult. Society, nation, science, and life. So I'll talk of all these engraftments, not necessarily in that order perhaps, but this is challenging, isn't it? So first, what you have to do is do your own SWOT analysis. What are your strengths? What are your weaknesses? What are your opportunities? And what are your threats? You are the best person, but you should also have a friend, right? Who is not a yes man kind of person, who will tell you what the truth is. If you can't speak well, or if you get angry easily, right? That person should point it out. Peter Drucker, he's a famous management guru. Back in 1960s, okay, he said, for business, mind you. Finding and occupying a specialized niche can be a powerful strategy for business success. Identifying a market segment with limited potential that others are overlooking, right? Then you can become a dominant player there. Do not think that you are a hematologist. I know we cannot have the luxury of being a myeloma specialist or of being a GVHD specialist or of being a inhibitor immune tolerance induction specialist. But in spite of seeing different kinds of patients, try to develop your niche. And for that, you have to understand what you're good at, right? These are your strengths. Can you do problem solving well? Do you love bedside teaching? Do you have strong motivational skills, organization skills? Where do you thrive? In small groups or in large patients? Are you an excellent communicator? I talked of where you need to engraft. The first concept was workplace. Don't think that you have a single workplace, right? Workplaces can be of different types. It can be government. Again, government is autonomous, like AIMS New Delhi or PGI or now JIPMER. Central government institutes and state government institutes. State government centers of excellence, state government medical colleges. All this can be a workplace. Not for profit, like trusts, right? So CMC, Amrita, these are trusts. And Niti Aayog has recently published a paper on how they run. You can go through it in your leisure time. And then the corporates. These corporates are not the manufacturing industry, right? They are the healthcare corporates. But they can again be global, like IHH, Gleneagles, and others, or they may be local who are slowly selling their business to the global corporates. Then you can have group practice. In India, you have a Mumbai Oncology Group, or you have a Hematology Cancer Group, and they have merged. They are all into group practice. I'll give you an insight into this. And there's another model that is a doctor entrepreneur, which I call docpreneur, and that is in Atmanirbhar Bharat and Atmanirbhar model, right? So let me take you through a ramp walk of all these models and see what is their SWOT analysis. After doing your SWOT analysis, you look at the model. Government model, job security with defined pay scale pension benefit, high patient volume, so you get a good clinical exposure, especially in early career, this is required. You get opportunities for teaching, training, research. Subsidized or free healthcare. There is no ethical conflict in patient affordability, but there can be. Sometimes you'll feel guilty that you're telling a patient that because you can't afford, say, ruxolitinib or say some newer drugs which are still within the innovator exclusive marketing rights. But you usually have protected working hours compared to private setups in most cases. But sometimes you can be on duty for 24 to 36 hours. What is the weakness of a government model? Bureaucratic delays in decision making, including your principal and director. And let me tell you, doctors are the worst bureaucrats. Delays in procurement, delays in approvals, limited autonomy in patient management. It might be protocol driven or depending on what drug is available, especially free of cost. The infrastructure and equipment are often under-maintained. The equipment might be there, the consumables might not be there. There might not be an annual maintenance contract, and they are out of order. There is a slow career progression due to seniority-based promotions, right? And if you are a teacher, so you have those norms when you become an associate professor, additional professor, and a professor. What are the opportunities? You can influence health policy and public health programs, both at the central level and at the state level. You can get access to rare and complex cases because they will only come to you. You can increase your publication and your visibility. You can collaborate with national and international bodies for multi-center trials. Even Indian trials have to have government setups. And there's a possibility to develop subspecialty like hemato-oncology, immunohematology, BMT, All these things. These are your opportunities. But what are your threats? Political interference in transfer and posting. Politicians may misbehave with you also. Burnout from overcrowding and understaffing, right? You'll be told whatever you have, you do with it. There's a risk of violence against doctors, and this risk is increasing day by day in high pressure settings. And there's a rapid migration of talent to better paying sectors. You train your nurses, you train your medical technicians, and they go in search of greener pastures. Even your junior doctors may go, right? Now, let us go to the corporate, right? Strengths, state-of-the-art infrastructure, advanced diagnostics, higher remuneration potential, especially for the senior consultants, better support services in terms of nursing diagnostics. You even have a marketing division, right? I don't know what they do because I don't have much experience, but you have freedom to build a personal brand with hospital support. But sometimes the hospital would like to promote their brand instead of promoting you. So it is important that you look at it carefully. What are the weaknesses? Profit-driven decision-making. This can compromise your clinical autonomy. This is the elephant in the room. I'll discuss certain other elephants also. There's a pressure to achieve revenue targets and procedural volumes. Are you not doing unnecessary interventions or investigations? Sometimes it is contractual employment. There is less job security. And during COVID, we saw that even the salaries were suddenly drastically reduced. There can be possible conflicts with your ethical standards or the standard ethics in over-investigation or over-treatment. Okay? We cannot close our eyes to it. Opportunities, yes, you can get access to cutting-edge therapies because the more expensive they are, they think, okay, revenue would be better. So CAR-T gene therapy, you'll be networking with national and international experts. You have potential to lead specialized clinical programs with hospital funding. You can be a clinical lead director. You can engage in medical tourism opportunities, which the hospital will undertake. What are the threats? Corporate restructuring or mergers are affecting job stability. Though it has not affected healthcare to that extent, we are seeing it in the IT sector. But the way the big sharks are gulping up the smaller hospitals, this might come. Damage to reputation from hospital-wide controversies. You are an ethical person, but the hospital recently did something which was not correct. You suffer. There's heavy competition from peers in the same network, and the management would love to keep you insecure, right? So you cannot take leave. If you go, they will put someone else. They might not form a department also. And regulatory changes can impact the profit margins. This is about corporate model. Now, not for profit model. Well, mission-driven work with strong ethical alignment. Sometimes the pay is low, but the motivation is there. You can get autonomy in clinical decisions. Because of trust-based care, you can get a close doctor-patient relationship, which is very important. There are opportunities for community engagement and outreach, but it has its own weaknesses. Lower pay compared to corporate and even some government posts, limited budget for high-end infrastructure, high reliance on donations or grants. So there's a financial uncertainty. If there's a religious guru who gets all the grants, and if that person dies, there can be problem. And sometimes there are less structured human resource policies. So you never know what is happening. It might not be very transparent. Opportunities, there's a scope for innovating low-cost treatment models. You can get access to philanthropic funding for research and programs. You can build grassroots public health impact in underserved population. And you can share and shape the hospital policies directly because people would listen to you even if you are not getting enough revenue. What are the threats? Sustainability issues during economic downturns like COVID, burnout if workload is high but remuneration is modest. Family may get angry with you. And difficulty in retaining again young talent like in the government sector because they would prefer high-paying jobs. Group practice model. Now, what is this model? You have shared resources. So diagnostics, administrative staff, rent reduces the costs. You can have collaborative patient management with cross-referrals. Someone does hemophilia, someone does transplant, someone does phase 1-2 trials. You refer to them. You can have flexibility in work hours and decision-making. If someone is sick and you don't attend, still someone will do your work and you'll earn a basic minimum to support your family. You're not a daily wage worker. And you can retain your individual professional identity while gaining the group strength. But what is the weakness? Profit sharing can create internal conflict, especially if it is not transparent. Unequal patient inflow against, say, X and Y may cause resentment. Limited access to very high-end procedures unless you have a hospital tie-up. There, obviously, there can be a hybrid model I'll discuss, and you need strong legal and partnership agreements. Otherwise, sometimes you lose everything. What are the opportunities? You can expand to franchise or chain model like MOG or HCG have done. They have been funded by Tata Capital. Niche specialization like pediatric hematology group, thrombosis clinic, bleeding disorders clinic. Collaborate with diagnostic chains. You need not do everything yourself. You can have revenue sharing models, B2B models, and adapt quickly to telemedicine and home care trends so that people are not left without anything. What are the threats? Group resolution if partners' visions diverge. And you'll always have a competition from corporate OPD chains. They may badmouth you also. Regulatory scrutiny on your clinic licensing, biomedical waste, fire safety license, and all those things, right? So let's come to docpreneur. Full autonomy in clinical and business decisions. You are the boss. You are the CEO. You can create a unique patient-centric model. You can have direct control over branding and your reputation. And you can develop long-term wealth through asset ownership. But what are the weaknesses? High financial risk in setup and operations. You may lose most of the hair which you had, because you have to repay the bank loan or wherever you got the investment from. High administrative burden, less clinical time, and it needs business acumen beyond medical skills. So you have to have some knowledge of administration, marketing, and difficult to compete with corporate hospital who always have deep pockets. But you can again create niche excellence centers. As I told you, integration of telemedicine, research, education, potential to attract investors or scale up. And you can pivot services because you do not need board's permission and all that. On emerging healthcare trends, you can do it fast. You can implement AI and digital health. What are the threats? Economic downturn can affect patient inflow. Rapid technological changes demand constant reinvestment. Litigation or regulatory non-compliance risk and pressure from larger corporate chains who are there next. So I have talked of the 5 models. Within these models, there are certain things, which is the elephant in the room, which are very less discussed. We cannot close our eyes. Revenue-based targets, as I already told you, changing public perception, especially of corporate hospitals, which may hamper the doctor-patient relationship, administrative overload, unnecessary tests and procedures, pharma and hospital kickbacks. These actually can hamper your ethical alignment and let you have a peace of mind. So if I prepare a matrix of the 5 models, right? Government hospital is good in terms of stability and ethical alignment. Income potential, not that good. Corporate hospital, income potential, very good. Ethical alignment, not that good. Not-for-profit, ethical alignment, good. Again, income potential is low. Group practice, total score 18, similar to not-for-profit. But here, the challenge is also in stability and income potential. Doctorpreneur, potential is the sky. Autonomy is the sky. Growth opportunity, but stability is only 1. So, if I design a radar chart for especially people who are just starting their career in clinical hematology and use the 5 alignments, ethical, stability, autonomy, growth, and income potential. This is how it stands out. Each has its own merits and demerits. There is never a perfect model never a perfect workplace. So what do? It depends on how many hats do you want. Even if you don't want, other than a healthcare provider, you have to be an advocate, activist, teacher, if not to students, to nurses, to medical technologists, genetic counselor, researcher, key opinion leader. This is actually a term used by the industry, pharma, policymaker, and sometimes you only have to be the fund generator, right? Even in government sector, now it is said you get your own funds for research. And then obviously you have to be an administrator. So you have learned how to provide service, that too clinical service, some form of teaching, research. What about innovation and what about administration? These are the 5 components. You do your analysis and take a decision. And how do you choose the niche or the organization? Current organization versus future organization. What is good? What is bad? Right? So you do a 2x2 chart. Always ask from people who have left that organization. Those who are in that organization may not reveal the truth. There's a hybrid path. I was a part of it. And many successful hematologists, I do not know what success means, like part-time government with private practice, balancing service with income, but you burn the candle at both ends. Academic position plus consultancy. So teaching while maintaining clinical expertise, research focus plus clinical work, advancing science while treating patients, urban base and rural outreach, trying to address healthcare disparities. So the modern Indian hematologists, these models are not watertight. We often wear multiple hats, creating a career mosaic that maximizes impact and satisfaction. But remember, you should not be afraid of crossing sectors, career transitions. Like you can go to government, from government to private. Advantage would be higher compensation, better resources, but you have to adapt to profit-driven metrics, potential ethical pressure. If you want to go from, say, private to academic, you'll get teaching satisfaction, research opportunities, but your income will reduce. Publication expectations will rise. You'll not be promoted if you do not publish. If you want to go from clinics to the industry, like what David Stisma or others in US are doing, going right from Dana-Farber to Novartis. Advantages are work-life predictability, but you lose direct patient care and you have to adapt to the government culture. Urban to rural, greater impact, less competition, but resource limitation, professional isolation, you might not get all the infrastructure. So career transitions are increasingly common. Remember, change is the only constant in your professional journey. So maintain relationships across sectors to keep options open. Even if you resign from one place, do not burn the bridge. This is what I have learned. Now, if you're an early career, you can benefit from starting in government or corporate setup for exposure and stability before moving to group practice or entrepreneurship. Mid-career people, you can transit into not-for-profit or group practice for work-life integration and better autonomy. Doctor entrepreneurship works best when such strong patient base is there. You are a brand, network is established because the financial risk is substantial. So how do you take a career decision? I've talked about VUCA. Let me talk about compass framework. And I'll give you an example, right? This may be a practical example for some of you. You want to take a career decision whether you want to join a specialized BMT center or a general hematology department. C from campus. Capacity. Do I have, can I develop the specialized skills if required? Opportunity. Is BMT growing in my region? Is there demand? Meaning, does this specialization inspire me? Why? Or if it doesn't inspire me, why? People, this is a critical path, right? Who will mentor me? What's the team culture? Is it toxic? Is it authentic? Does this align with my passion and values? Is it stable? What are the emotional and financial complications? What is the sustainability? Is this viable for my long-term growth? So this is your compass. You can do an exercise after this webinar. Think of a recent career decision you made or you're considering and apply the compass. See if you get new insights. there are certain ethical anchors in hematology practice. We all know that. Transparency. Discuss all available diagnostic options, not just those available at your facility. And will it benefit the patient? Accountability. Acknowledging errors and learning from them rather than deflecting the blame to someone else. You can take responsibility for your clinical decisions. We do make mistakes. And you have to differentiate between need and greed. Choose investigations and treatment based on clinical necessity, right? Instead of kickbacks and other things. There are a lot of vulnerabilities here, and the industry always looks for vulnerable physicians. There are so many ethical dilemmas in Indian hematology. Who gets the limited blood products during shortage, resource allocation, rationing? When patients cannot afford standard first-line treatments, pressure to refer patient for commission. This is a reality. Sometimes they are called referral fees, right? Over investigations, experimental treatment, when to offer versus standard care, and cultural considerations, respecting family decision-making while protecting the patient's autonomy. These are very difficult to take a decision. But having a structured approach to these dilemmas helps maintain integrity under pressure. I'll show you one structure. It's called the 4-box method. First box, medical indications. What is clinically indicated and what evidence supports this approach? Patient preferences. What does the patient want? What the family members want? Are they fully informed? What are their cultural considerations? What is the quality of life? Patient might survive for a few more days, but in the hospital in ICU. What is the trade-off? And the 4th box, what social, economic, and legal and resource factors are relevant? Remember, medicine is not a science. It is a social science. And this is not me speaking. This is Virchow speaking, right? So many years back that medicine is a social science. You can then navigate complex decisions by looking at all the factors. You know, what is our greatest vulnerability? It's FOMO, the comparison trap, the fear of missing out. And this is taken advantage by people who want to exploit this. There are unique manifestations in medical careers. Career path anxiety. My batchmate joined Apollo while I am still at a district hospital, so I will not attend the reunion. Publication pressure. Everyone seems to be publishing in international journals except me. Fellowship frenzy. Should I be doing another super specialization? Lifestyle comparison. Other doctors have bigger homes and better cars. Social media always amplifies achievements while hiding the struggles. So if you are following people on Facebook, Insta, or LinkedIn, you are in for trouble. FOMO can lead to hasty career decisions, burnout, and diminished satisfaction with otherwise meaningful work. You can do meaningful work in a district hospital. Don't bother whether there is external validation or not. And empathy should be at the heart of hematology. You have to recognize the patient's emotional states and respond appropriately. Impact of diagnosis like leukemia or thalassemia. Acknowledge the financial toxicities of long-term treatment. Communicate in ways that respect the education levels of that patient, the cultural background, and support the patients through treatment decisions with compassion. So you can draw an empathy map, right, which tells you why the person is behaving like that. This I had discussed when I was discussing design thinking. But remember, there is an empathy burnout paradox. High empathy can lead to also the empathy paradox of burnout. It increases your vulnerability to burnout. Sometimes you have to be objective to save your own life. So you have to build emotional resilience. It should be a reflective practice. You maintain a professional journal to process the difficult cases. You may put it in your personal WhatsApp to you. And then peer support. Create or join groups where physicians discuss emotional aspect. Never be alone 24/7, especially managing AML and all types of difficult GVHD. trusted colleagues. They provide validation and perspective. Connect with people who can mentor you, who have navigated similar challenges. Learn from their experiences and coping strategies. And you have to be mindful all the time. Practice present moment awareness during clinical encounters. And please heal yourself. Good sleep, nutrition, exercise. People tell me I don't have the time, It's just like you say, because I'm driving the car, I don't have time to fill up petrol. Look at ergonomics, because physical well-being directly impacts clinical judgment, your empathy reserve, and your career longevity. It's a marathon. It's not a 100-meter dash. Financial well-being. We are never taught about this, right? You should have a 6 months of expenses before other investments as an emergency fund. You should have insurance, not only professional indemnity, health insurance, life insurance, disability insurance. Whatever minimum amount, go in for SIP, Systematic Investment Plan, National Pension Scheme, tax planning, 80D medical deductions. If you buy a stethoscope or a computer, it's a professional development, right? Because financial stress will always keep you unhappy. You can stay updated. This is the best time to learn with all sorts of AI tools, including LM Notebook or ChatGPT. There is a digital transform in hematology, like telemedicine, digital pathology, data-driven practice. Try to keep updated. What are the emerging challenges in Indian hematology? Antimicrobial resistance, rising therapy costs, geographic disparity, lifestyle blood disorders, and very difficult to get India-specific guidelines unless you formulate them. So, beyond publications and position, how do you build your legacy? Your true legacy, and I can vouch for it, will be measured by the patients whose lives you touched and the suffering you alleviated. This might not be published in high-impact journals. The junior colleagues you mentored and inspired, the ethical standards you upheld and modeled for others, right? Walk your talk. The innovations or improvements you contributed to patient care, and the policies or practices you influenced, either through politicians or through bureaucrats. Legacy thinking isn't just for senior doctors. Ask yourself regularly, what impact do I want to have when I look back on my career, right? So, I talked about the niche. How do you choose the niche? Visualization. Create your 5-year vision map. What would be your clinical expertise in 3 to 5 years? What skills and certifications will you pursue? Where will you practice? What professional networks will you cultivate? How will you contribute to science? How will you grow beyond medicines? And how will you adapt? What are your priorities? This is the last survey I have. Please choose. Please choose. I'm giving you 30 seconds. I think most of you had logged into Slido. Even if I get 8 responses, I'd be so happy. Because what is your priority in life? I'll speak on that for the next 8 minutes. I've had 4 responses till now. 5. Come on. There's no prize for first answers, but please share your opinion. Money, power, job satisfaction, awards, luxury items, health, happiness. Well, I've got 6 responses only. No problem. Job satisfaction. Oh, 83%. 17% luxury items. People do not want money, do not want health, do not want happiness. Huh? Fine, no problem. So can money buy happiness? Well, in a survey, it was said that most of the people felt that it cannot buy happiness, but poor can make you miserable, right? So this was a study between life satisfaction and income. And it clearly showed that there was a negative correlation in the Scandinavian countries where you have a good quality of life. If you look at the American Freshman Survey national norms, well-off financially were only 42%. It improved to 71%, right? But developing a meaningful philosophy on life actually decreased from 86% to 52%. Okay, leave the American freshman. 1940s, you had so little stuff. Now you have iPads, laptops. Average happiness has decreased from 7.5 to 7.2. So, doesn't money buy happiness? Your country matters. In poorer nations, because even your housing, your education, your hygiene, your health is not guaranteed, up to a point, it can improve. But then it actually becomes a plateau, just as in developed nations. So this was a study published in PNAS by Daniel Kahneman and his group. So ultimately, as your financial income increases, what does increase? Well, stress actually increases. Positive effect also decreases, right? So this was what David Stisma had shared in Facebook long back. This was how he measured success. I told you I do not know the definition of a successful hematologist. But you have to envisage the hurdles. Do not have great expectations. You have to understand the mindset of the colleagues, the resources available. Is there safety? Is there a good leadership? Are you becoming bored? Is there teamwork? Does the team matter? Is everyone criticizing you or everyone demotivating you? So, I do not call it work-life balance because it seems that work goes at one direction and life goes in another direction. Actually, it's an integration. That is how Ratan Tata used to describe it. They're interconnected aspects. You have to calendar block family events with the same priority as your professional commitments. Create clear policies for after-hour communications. Being on the phone while you're sitting with your child does not improve matters. Nurture non-medical aspects of your identity and interest. Develop a hobby. Develop creativity. Chase creativity. Location strategies. Consider proximity to work when choosing housing to reduce commute stress. Enjoy. This is with my family members. This is with my MBBS batchmates. So we know that there can be graft failure or there can be graft rejection. How do you overcome? Immunosuppression. So the most important question you can ever ask is whether the universe is a friendly place. Things don't spiral out of control when we surrender them. They spiral out of control when we try to control them. You can't control your own rage. You can't control your spouse. How can you control the universe? So tolerance, like immunotolerance, is most important. And how do you engraft? This is what the Japanese call ikigai. When what you love, what you're good at, what you're paid for, and what the world needs all converge here, right? But what is the real life data? It is not easy. I went through the surveys in India and only 10 to 25% experience both passion and fulfillment. 75%, unfortunately, do not have that luxury. So, if I compare engraftment with professional engraftment, just like an adequate cell dose, you need an adequate skill dose. You need a healthy stem cell source and you need a healthy mentorship source because some mentors are like haploidentical donors with GVHD risk, workable, right? Optimal conditioning means optimal preparation for your skill set and your mindset. Immunosuppression. Get rid of your ego. Humility to prevent rejection in society. Good marrow microenvironment. Job satisfaction. That is what you voted for. And for preventing infections and politics both spread fast. Avoid politics at all levels. Adequate nutrition. GCSA works for cells, but for careers, the only growth factor is who knows you and respects you. Close monitoring post-transplant. And just as you have patience during engraftment lag, you should have patience during career lag. Career does not go like this, right? It goes like this. You have to have that patience. I'll stop with the story of the Karela fry. Swami Abhayananda used to go to his followers' homes. And in breakfast, one day he went to a home and He saw there were a lot of things, but this was this bitter gourd, Karela. He said, this is so bitter. So let me finish it first and then enjoy the other goodies. So he took it. The host, the lady of the house, thought, oh, Swamiji likes Karela. So she gave another bowl. He had to take it. And the message spread that Swamiji loves Karela, and for the rest of his life, he had to have Karela for his breakfast. This is what tolerance is. So make aligned career decisions, practice ethical hematology, balance empathy with resilience. Do not destroy yourself. Prioritize holistic well-being. So my take is, whether it's stem cells or carrier cells, both need the right preparation and the right niche. If you don't do it, you will get GVHD, grumpy veteran hematologist disease. Thank you for your patient hearing. I think I'll stop sharing.
Thank you, sir. Wonderful talk. Eye-opening talk. No words about it. The way you spoke was actually, there is no words. We were on another world, actually. We were actually want you to listen you again and again, because the talk was so superb. We were actually in the spiritual world to what you were speaking about. Thank you so much. I think this was a
Thank you.
real world scenario, what we all the hematologists are going through. After specialization, we ourselves don't know what we are up to and what we are actually going to do and what is our goal. We don't know. We are back for money, back for patients, but nobody is happy. So definitely, yes, the job satisfaction, as you said, that is the only way to go. And you brought out the right thing today, sir. Thank you, sir. Wonderful lecture, fantastic lecture. Anybody has any question? Dr. Gopinathan? Dr. Gopinathan is very well settled.
Yeah.
Dr. Gopinath, anybody else? Dr. Aditi? Dr. Raghavendra? Dr. Shilpi? One question has come. Yeah, Dr. Shilpi.
Sir, thank you for the insightful lecture. So it was actually unconventional lecture on an extremely important topic. The one thing which I really liked, sir, we can do meaningful work even in a district hospital. It's so true. And when the patient comes back to you and say thanks, and his relatives come and say thanks, so it's so
Yeah, it's so heartening,
enlightening.
you know.
Yeah,
It's
yeah,
so
it's so
heartening.
heartening. Just
Never fall prey to FOMO, okay? Never fall prey to FOMO. Never.
Sir, I will ask you one question. After the 5 models, what you showed, what is the
Yeah,
best
yeah.
according to you?
Well, there's no ideal best model, but as I told you, you can transition also. So, you know, our generation, I do not know, now there's almost a generation gap with the next. Our generation thought that, okay, I join a teaching institution, I remain there. Now the thought is slowly coming that you can transit. But I remember my mentor, Professor Rajat Kumar, telling me that, Prantar, when you're 40 years old and you're doing the same work and you ask for transplant unit, you ask for some things, you cannot get it done, I know that you will leave your job. So what happens is, as I told you, early career people, if you want more experience, you can go into government or not-for-profit where you get more patients. If you want technologically superiority, you can go into corporate also, but be ethically aligned. Then slowly you can build your group practice with like-minded colleagues who are not afraid that, you know, they will steal. You should not be afraid that they will steal your patients. That trust should be there. And if you go into group practice, you can build an institution yourself and you can become a doctor entrepreneur. So it's a gray area. That's why I showed you the radar chart and I showed you the matrix scores. Now, the mindset should not be same. It should be different for different people, right? So no problem. Whatever you think is best, but remember that you are not compromising on certain things. That's all.
There are some questions which are related. 2 or 3 people have asked basically, and they put me on my WhatsApp also to ask you.
Okay.
Career in India versus career outside India. Whether they must shift out of India for a better job opportunity in the same field. What is your take on that?
Yeah, again, they should analyze that 2x2 chart is most important. Where they're trying to go, what is good about it, what is bad about it, right? So I always tell that if you go to a so-called developed country, right, the problem is that as far your life score is, it is always 3. You can always be, if you consider India as a second-class country, you'll be a first-class citizen in a second-class country, score 3. If you go to a first-class country, you will be a second-class citizen of a first-class country. So your score will again be 3. But if your work environment is better, your colleagues are better, your mentoring is better, and your peace of mind is there, you can always go because you can serve other people also. But I think India now has more opportunities. But I can tell you, even Southeast Asian countries are looking for Indians. Like I met someone from Malaysia, and the first thing she did was she thanked Indian doctors for running their healthcare system. I think UK prime ministers sometimes thank Indians only. So Indians are there everywhere. But let me tell you something. Do not go by the pay package only. You know, if you convert US dollars and pounds to Indian rupees, they look very good. But who will take care of your parents and your children? And if you don't want to wash your dishes every day, that quality of life should be kept in mind. But I have never worked abroad, so I do not have an idea. I have just done an observership in King's College. Everything looks rosy on the other side of the river.
Fully agree with you, sir. Absolutely.
One question one person has asked Dr. Archit Pandari Pandey.
Yeah.
How to collaborate and not compete?
Yeah. So from school, we have been told that our classmates are competitors. So yesterday on Independence Day, I went to a school and told them that they are not your competitors, they are your collaborators. If you really like to compete, you compete with the Chinese, with the Koreans, with the Japanese, right? So even in life, if you're not collaborating, can you be on call 24/7 into 365? Is it possible humanly, especially in hemato-oncology? So everyone has their strength and weakness. As long as there is transparency and accountability and there is trust, it is very easy to collaborate. Even with scientists, with basic scientists, with engineers, that trust should be there. You know, when you collaborate with basic scientists, do not remain sample suppliers. You design what answer are you seeking to. You actively participate in that research. Then only it's a meaningful collaboration.
One question.
Yeah.
One person has asked, maybe a little bit a silly question.
No. Tell me.
So, what do you actually mean by work-life balance?
So I did not mention work-life balance. I talked about work-life integration. You know, I was listening to a psychiatrist. So he said, you know, you talk of family and everything. Let me ask you, after 10 years, what do you want to be known as? Only as a good father or also as a good hematologist, right? And you have to remember that the work helps you support your family, nurture your family. So don't look upon it as something which is against your, family time. You have to integrate it. Don't let it overlap. Don't try to do multitasking. And give protected quality time to your family. That's why I told you the best part of doctrinership and this group practice is you can have flexible working hours. But there cannot be a balance. You need to do both. How can you be a good father if you are not even earning enough for the child's education? Right? So it has to be not a balancing trick. It has to be integration of one into other. And like some of the entrepreneurs today always say that if you're happy to go to your work and again you're happy to come back to your family, that is the ideal work-life integration. That is what I mean.
Perfect. Dr. Gopinathan.
Yeah.
Yeah. So good evening, sir. Nice listening to you as always.
Yeah.
Yeah. So my question is like when we finish our graduation from kind of institutes and move away to our own individual practices, obviously the number of patients that we see gets a bit lesser.
Right.
But still, if you want to do kind of some kind of research work in an institute, it seems very easy to apply for an ICMR grant. We have very much strong backup for funding. But in
Right.
private practice, I suppose any other trial investigators also, if you approach, they will just be asking, sir, how much CML patients do you see? How
Yeah.
many lymphoma patients you do see?
Mhm.
So he's just checking like your center is really fit to run that particular trial or something.
Right. Right.
So in such a way, how can we, if you want to do an investigator-initiated trial, or if you're interested as a part of some kind of research work, how can we overcome this particular situation?
Group practice. That is the only way. That is how the Americans do. Okay. Get 3 or 4 hematologists together. Each will have some patients. Each will have some kind of infrastructure, and each can do it together. As far as infrastructure, particularly, in early career, you want to do transplant. You cannot develop a transplant facility overnight. You can use the facility of a corporate hospital. But as I tell all my students, use the corporate hospital as a 5-star hotel. You tell, I will use your facilities and pay for it. But even if you are a single practitioner, develop your own team of nurses, paramedics, apheretics, so that you can maintain the quality. They remain with you. And Indian income tax laws are very clear. If you are paying your nurses and all, they are deducted from your taxable income. So even if you are in a single center and you want to work in another place, the critical mass is the human resource. Develop a good team whom you can trust and those who can trust you. And when they face a problem in their career or family, you'll be there for you. Once that team is developed, the numbers will automatically come, and people who are looking for clinical trials will also come to you. But for doing collaborative research, you can even work with your colleagues who are on teaching institutions. You can still be a co-investigator and do the work, right?
Okay.
So it's not that ICMR will only give to a government investigator. Nowadays, ICMR, Department of Health Research, they all promote multi-center research, implementation research, collaborative translational research. This all can be done without being directly an employee of a large institution.
Thank you, sir. Thank you. I'll try implementing the same. And maybe in
And you
in
let
your
me know.
Yeah, in your further lectures, then I'll put back the same feedback to you.
Okay, thank you.
Yeah, thank you.
Thank you, Dr. Gopinathan. So that's all, sir. Thank you so much once again. Again, a fantastic lecture, wonderful as always. No words for you. A really eye-opening world you put everybody into. It was a spiritual journey, I may say. Wonderful real life scenario and much thing to learn from you, sir. Thank you so much.
Thank you.
A lot.
My pleasure.
Thank you.